A critically ill patient arrives in shock with severe breathlessness and cold, clammy extremities. This is a life-threatening cardiovascular emergency requiring immediate recognition and stabilization. Cardiogenic shock is defined as low cardiac output causing life-threatening end organ hypoperfusion. Diagnostic criteria include systolic blood pressure less than 90 millimeters of mercury, or mean arterial pressure less than 65 millimeters of mercury for at least 30 minutes. Most cases follow acute myocardial infarction, especially anterior wall infarction. It accounts for nearly 80% of cardiogenic shock cases. Mechanical complications include papillary muscle rupture, ventricular septal rupture, and free wall rupture. These dramatically worsen mortality and require immediate intervention. Pathophysiology begins with reduced myocardial contractility, leading to decreased cardiac output. This triggers systemic hypoperfusion, lactic acidosis, and progressive multi-organ failure. The SCAI classification stages cardiogenic shock from at risk to E extremis. Stage C represents classic shock requiring vasopressors or inotropes. Patients present with hypotension, cool extremities, oliguria, and altered mental status. Jugular venous distension and pulmonary crackles are common findings. Echocardiography is essential to assess left ventricular dysfunction, valve rupture, or septal defects. It rapidly defines the cause of shock at bedside. Immediate coronary angiography is indicated in all myocardial infarction-related cardiogenic shock. Early revascularization improves survival significantly. The shock trial showed early revascularization saves lives with absolute mortality benefit. Culprit shock supports culprit-only PCI strategy. Norepinephrine is the first-line vasopressor to maintain mean arterial pressure above 65 millimeters of mercury. It improves perfusion with fewer arrhythmias than dopamine. Dobutamine is added when cardiac output remains low despite adequate blood pressure. It improves contractility but may cause vasodilation. Dopamine is generally avoided due to arrhythmia risk and worse outcomes. Levosimendan shows no proven mortality benefit in cardiogenic shock. Fluid administration must be cautious, as excess volume worsens pulmonary edema. The goal is optimized preload without congestion. Intra-aortic balloon pump shows no mortality benefit according to IABP Shock II trial. Mechanical circulatory support is reserved for selected cases. Impella and extracorporeal membrane oxygenation provide advanced support in refractory shock. These are bridge therapies to recovery or transplant. Right ventricular infarction requires careful preload optimization. Excess fluids can worsen septal shift and reduce left ventricular filling. Papillary muscle rupture causes acute severe mitral regurgitation with pulmonary edema. Emergency surgery or percutaneous repair is required. Ventricular septal rupture creates a left-to-right shunt and rapid hemodynamic collapse. Surgical closure is definitive treatment. Free wall rupture leads to cardiac tamponade and sudden pulseless electrical activity arrest. Immediate pericardiocentesis and surgery are required. Acute fulminant myocarditis mimics myocardial infarction but shows global ventricular dysfunction. It requires supportive care and possible mechanical support. Acute pulmonary edema presents with severe dyspnea, hypoxemia, and crackles. It is often triggered by acute left ventricular failure. Oxygen therapy targets saturation above 92% using high-flow nasal cannula or non-invasive ventilation. Intubation is required if respiratory failure progresses. Nitroglycerin is first line for preload reduction in hypertensive pulmonary edema. Intravenous infusion starts at 5 to 10 micrograms per minute. Furosemide is given at 0.5 to 1 milligram per kilogram intravenously. It reduces preload through ventilation and diuresis. Morphine 2 to 4 milligrams intravenously may reduce anxiety and preload, but must be used cautiously due to potential harm. Nitroprusside is used in hypertensive pulmonary edema, but requires arterial monitoring due to risk of hypotension. ACE inhibitors reduce preload and afterload in selected stable patients. They must be started at low dose with careful monitoring. Positioning the patient upright reduces venous return and improves breathing. This simple maneuver rapidly improves oxygenation. Renal replacement therapy is used for refractory volume overload or severe acidosis. Continuous modalities are preferred in unstable patients. Arrhythmias worsen pulmonary congestion by reducing cardiac output. Immediate cardioversion or rate control may be required. Acute coronary syndrome with pulmonary edema requires urgent revascularization. Percutaneous coronary intervention is preferred over fibrinolysis. Takotsubo cardiomyopathy shows reversible left ventricular dysfunction triggered by stress. Recovery is usually complete with supportive care. Extracorporeal membrane oxygenation is considered in refractory hypoxemia or cardiogenic collapse. It provides temporary cardiopulmonary support. Cardiogenic shock and pulmonary edema represent a single spectrum of acute cardiac failure. Early recognition and rapid intervention are critical.